all the work, but I'm happy that I'm in the civil side. So, sorry, now mention what actually work, but I know you like to keep it very simple.
Really? Sound. ಊಟ
ಸರ್ ನಮಸ್ಕಾರ ಸರ್.
ಹಾ ನಮಸ್ಕಾರ ಸರ್, ರಾಜೇಶ್ ಸರ್ ನಮಸ್ಕಾರ. ಶ್ರೀನಿವಾಸ್ ಸರ್ ಫೋನ್ ಹಚ್ತಾ ಇದ್ದೆ ಸರ್. ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್. ಹಲೋ ಸರ್, ಗುಡ್ ಈವ್ನಿಂಗ್. ಅದೇ ಈ ಪ್ರೋಗ್ರಾಮ್ ಸ್ಟಾರ್ಟ್ ಆಗ್ತದೆ ಸರ್, ಪ್ಲೀಸ್ ಸರ್. ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಡಾಕ್ಟರ್ ಮಹೇಶ್ ನಮಸ್ಕಾರ ಸರ್.
ನಮಸ್ಕಾರ ಸರ್.
ಹಾ ನಮಸ್ಕಾರ ಸರ್. ನಾನು ಪ್ರೆಸಿಡೆಂಟಿಗೂ ಹೇಳಿದ್ದೀನಿ, ಅವರು ಕೂಡ ಜಾಯ್ನ್ ಆಗ್ತಾರೆ. ನಮ್ಮ IMA KSB ಪ್ರೆಸಿಡೆಂಟ್
ಓಕೆ ಸರ್.
ಡಾಕ್ಟರ್ ಚಿನಿವಾಲಾಲ್ ಅಂತ ಹೇಳಿ. ಆಮೇಲೆ ಸೆಕ್ರೆಟರಿ ಬಂದ್ಬಿಟ್ಟು ಅವರು ಸೂರ್ಯರಾಜು, ಹಿ ಈಸ್ ಬಿಸಿ, ಸಮ್ ಪ್ರೋಗ್ರಾಮ್ ಈಸ್ ಆಲ್ರೆಡಿ ಎಂಗೇಜ್ಡ್. ಆಮೇಲೆ ನಮ್ಮ ಡಾಕ್ಟರ್ ರಾಜೇಂದ್ರ ಪ್ರಸಾದ್ ಸರ್ ಇದ್ದಾರೆ, ಈಸ್ ಎ ಸೀನಿಯರ್ ಮೆಂಬರ್ ಆಫ್ IMA ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಕಮಿಟಿ. ಆ್ಯಂಡ್ ಮತ್ತೆ ಡಾಕ್ಟರ್ ಆದರ್ಶ್ ಆಲ್ಸೋ ಜಾಯಿನ್ಡ್. ಡಾಕ್ಟರ್ ರಾಜಲಕ್ಷ್ಮಿ ಮೇಡಮ್ ಆಲ್ಸೋ ಜಾಯಿನ್ಡ್.
ಸರಿ ಸರ್.
ಇದು ಟಾಪಿಕ್ ನಾವು ಕೂಡ ಎಲ್ಲರಿಗೆ ಹೈಲೈಟ್ ಮಾಡಿದ್ದೇವೆ ಸರ್. ಇಟ್ ಈಸ್ ಸಮಥಿಂಗ್ ನ್ಯೂ ಟೆಕ್ನಾಲಜಿ ಆ್ಯಂಡ್ ದ ನ್ಯೂ ಸಿಸ್ಟಮ್. ಒನ್ ಹ್ಯಾಸ್ ಟು ಗೋ ಥ್ರೂ ದಿಸ್ ಆ್ಯಂಡ್ ದೇ ಕ್ಯಾನ್ ಅಪ್ಲೈ ಇನ್ ಫ್ಯೂಚರ್ ಆಲ್ಸೋ. ಇಟ್ ಇಸ್ ಗೋಯಿಂಗ್ ಟು ಬಿಕಮ್ ಆಸ್ ಎ ರುಟೀನ್. So many people also ask, is it experimental or how is it anywhere in the city, which other country they have done, what is the successful result of this system? So ಅದ್ರ ಬಗ್ಗೆ ಜಾಸ್ತಿ ಜನ ನಮಗೆ ಕೇಳಿದ್ರು ಕ್ವಶನ್ಸ್. ಸೊ ಲೆಟ್ ಅಸ್ ಡಿಸ್ಕಸ್ ಅಂತ ಹೇಳಿದ್ದೀವಿ. ದೇ ಆರ್ ಆಲ್ಸೋ ಜಾಯಿನ್.
ಶೋರ್ ಸರ್, ಶೋರ್ ಸರ್.
ಡಾಕ್ಟರ್ ರವೀಂದ್ರ ಜಾಯಿನ್ ಆಗಿದ್ದಾರ ಸರ್?
ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಸರ್, ರವೀಂದ್ರ ಸರ್ ಜಾಯ್ನ್ ಆಗಿದ್ದಾರೆ ಸರ್.
ನಾನು ಈಗ ಕಾಲ್ ಮಾಡಿ ಹೇಳ್ತೇನೆ ಸರ್ ಅವ್ರಿಗೆ.
ಜಸ್ಟ್ ಒಂದು
ಆಯ್ತು ಸರ್, just 1 minute ಸರ್. ಜಾಯಿನ್
ಸರ್ ಪ್ಲೀಸ್ ಸರ್.
ಇನ್ನು ಸ್ವಲ್ಪ ಕೊಡಿ.
ಜಾನ್ ಇದ್ದೀರಾ
ಸರ್? ನನ್ನ ಕೋಸ್ಟ್ ಮಾಡಿದಾರ ಸರ್?
ಮಾಡಿದ್ದಾರೆ. ಓಕೆ ಸರ್, ಓಕೆ. ಆಮೇಲೆ ಸ್ಲೈಡ್ಸ್
ಐ ಕ್ಯಾನ್ ಮ್ಯಾನೇಜ್.
ಆಮೇಲೆ ಸ್ಲೈಡ್ಸ್ಗಳು ಇದಾಗಿದ್ದಲ್ಲ ಸರ್? ಸ್ಲೈಡ್ ಡಿಸ್ಪ್ಲೇ
ಏನು ಸರ್?
ಎಲ್ಲ ಸ್ಲೈಡ್ಸ್ಗಳು ಡಿಸ್ಪ್ಲೇ ಆಗಿದೆ ಅಲ್ಲ ಸರ್?
ಅಲ್ಲ, ಸ್ಲೈಡ್ಸ್ ನಲ್ಲಿ ಏನು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ ಸರ್. ಈಗ ಸ್ಲೈಡ್ ಶೋ ಮಾಡಿದ್ರು ಅವರು, ಏನು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ.
ಓಕೆ ಸರ್, ಓಕೆ ಸರ್. ಹಾಯ್ ಡಾಕ್ಟರ್ ಆದರ್ಶ್. ಹಾಯ್,
ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್. ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್.
ಗುಡ್ ಈವ್ನಿಂಗ್. ಗುಡ್ ಈವ್ನಿಂಗ್. ನಮಗೀಗ ಮಾಡರೇಟರ್ ಜಾಯ್ನ್ ಆಗಬೇಕಾಗಿತ್ತು, ಡಾಕ್ಟರ್ ರವೀಂದ್ರ ಸರ್. ಅವ್ರ ನಂಬರ್ ನಮ್ಮ ಹತ್ರ ಇಲ್ಲ. ಡಾಕ್ಟರ್ ರವೀಂದ್ರ ಸರ್. ರಾಜೇಶ್ ಸರ್, ಅವ್ರ ನಂಬರ್ ಇದ್ರೆ ಫೋನ್ ಮಾಡಿ ಸರ್.
ಯಾರು ರಾಜು?
ಸರ್ ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್. ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್. ಗುಡ್ ಈವ್ನಿಂಗ್.
ಸೂರ್ಯರಾಜು ಏನೋ ಬೇರೆ ಕೆಲಸ ಇದೆ ಅಂತ ಹೇಳಿ ಬರ್ತಾ ಇಲ್ಲ.
ಓಕೆ ಸರ್, ಹೇಳಿದ್ರು ಸರ್.
ಹೇಳಿದ್ರಲ್ಲ, ಯು ಕ್ಯಾನ್ ಗೋ ಹೆಡ್.
ಎಸ್ ಸರ್, ಎಸ್ ಸರ್, ಅದು ಹೇಳಿದ್ದೀವಿ ಸರ್. ಸಮ್ ಅದರ್ ಮೇಡ್ ಅರೇಂಜ್ಮೆಂಟ್.
ಓಕೆ ಓಕೆ ಓಕೆ, ಆಯ್ತು.
ನಮಸ್ಕಾರ ಸರ್, ಚಿನ್ನಿವಾಲ್ ಸರ್.
ನಮಸ್ಕಾರ.
ನಮಸ್ತೆ ಸರ್. ನಮಸ್ತೆ
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ ಸರ್.
ನಮಸ್ಕಾರ ಸರ್.
ಹಲೋ, ನಮಸ್ಕಾರ ರೀ.
ನಮಸ್ಕಾರ ಸರ್. ಲಕ್ಷ್ಮಣ ಸರ್ ನಮಸ್ಕಾರ.
ನಮಸ್ಕಾರ. ಏನ್ರಿ ಕಾವ್ಯಕರ್, ಆರಾಮದಿರ?
ಆರಾಮ್ ಸರ್, ಆರಾಮ್ ಸರ್.
ನಮಸ್ಕಾರ ರೀ ಲಕ್ಕೋಳ.
ನಮಸ್ಕಾರ ನ್ಯಾಷನಲ್ ಪ್ರೆಸಿಡೆಂಟ್ ರಿಗೆ. ಆರಾಮ್ ಸರ್.
ಡೈಲಿ ಅವ್ರ ಮೆಸೇಜ್ ನೋಡಿದ್ರೆ ನಮ್ಗೆ ಇದನ್ನ ಆಗೋದಿಲ್ಲ ಸರ್.
ಅಲ್ಲ, ಅದು ಕೈ ಎತ್ತಿದ್ದೊಂದ್ ಏನೋ ಹೇಳ್ಯಾರ, ನೋಡಿರೇನ ಅವ್ರದ? ಕೈ ಇಳಿಸ್ಬೇಡ್ರಿ ನೀವು, ಹಂಗ ಇಟ್ಕೊಂಡ್ರಿ. ಬ್ಯಾಡ್ ಬಿಡಪ್ಪ ನಿನ್ ಸುದ್ದಿ ಮಾರಾಯ. ದಿನ ನೋಡದೆ ಫಸ್ಟ್ ಮೆಸೇಜ್ ನಿಂದು 365 ದಿವಸದೊಳಗೆ 850 ಮೆಸೇಜ್ ಇರ್ತಾವ್ರವು. ಯಾಕ್ರಿ ರಾಜೇಂದ್ರ ಪ್ರಸಾದ್, ಆರಾಮದಿರ?
ಹಾ ಸರ್ ನಮಸ್ಕಾರ ಸರ್.
ನಮ್ ಪ್ರೆಸಿಡೆಂಟ್ ಹಂಗದಾರ ಸರ್, ಚನ್ನವಲ್ ಸಾಹೇಬ್ರು ಬಂದಾರ?
ಸರ್ ಇದಾರಲ್ಲ
ಅದ
ಸರ್?
ನೋಡ್ರಿ ಚಿನ್ವಾಲ್ ಅದಾರ ನೋಡ್ರಿ, ಕುಂತಾರ ನೋಡ್ರಿ ಅಲ್ಲಿ.
ಅಲ್ಲ,
ಚಿನ್ವಾಲ್
ಕೆಂಗೇಟಿ ಮಹಾರಾಜ್ ನಮಸ್ಕಾರ.
ನಮಸ್ಕಾರ ಸರ್, ಮತ್ತೇನಂತ್ರಿ?
ಚಿನ್ವಾಲ್
ಅಲ್ಲ,
ಚಿನ್ವಾಲ್
ನಿಮ್ಮ ಬಾಯ ನಿಮ್ಮ ಹರಕೆಯಿಂದ ಬಿಡನಾಳ್ ಅವ್ರ ಪ್ರೆಸಿಡೆಂಟ್ ಆಗ್ಲಿ.
ಆಗ್ತಾರ ಸರ್, ಹಾಕ್ಲಿಲ್ಲ ಅಂದ್ರೆ ಹೆಂಗ್ ಸರ್?
Definitely.
ಎಲ್ಲಾರ್ದ ನಿಮ್ಮೆಲ್ಲಾರ್ದು ವಿಶ್ ಇತ್ತಂದ್ರ ಆಗ್ಲಿ ತೋರಿಪ್ಪ.
ಆಗತ್ತೆ ಆಗತ್ತೆ.
ಡೆಫಿನೆಟ್ಲಿ.
ಅಲ್ಲ, ವಿ ಆರ್ ಪ್ರೌಡ್ ಆಫ್ ಯು ಸರ್. ಡೆಫಿನೆಟ್ಲಿ ವಿಲ್ ಬಿ ಎನ್ ಅವರ್ ನ್ಯಾಷನಲ್ ಪ್ರೆಸಿಡೆಂಟ್.
ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಆಗ್ಲಿ ತೋರಿ, ನಿಮ್ ಎಲ್ಲಾರ್ದು ವಿಶ್, ಎವ್ರಿಬಡೀಸ್ ವಿಶ್ ಡೆಫಿನೆಟ್ಲಿ ವಿಲ್.
Yes sir, yes sir.
ಒಂದ್ಸಲ ಡೆಲ್ಲಿ
ಇರ್ತದೆ ಸರ್. ಬಿಡ್ನಾಳ್ ಸರ್, ನೀವು ಪ್ರೆಸಿಡೆಂಟ್ ಆಗಿ ಮುಂದಿನ ವರ್ಷ ಬರಬೇಕು.
ಮಾಡೋಣ ಸರ್.
ಡಾಕ್ಟರ್
ಸರ್ ರವೀಂದ್ರ ಅವ್ರು ಜಾಯಿನ್ ಆಗಿದ್ದಾರೆ.
ಸರ್ ನಾನು ಜಾಯ್ನ್ ಆಗಿದ್ದೀನಿ.
ಎಸ್ ಸರ್, ರವೀಂದ್ರ ಸರ್.
ರವೀಂದ್ರ ಸರ್, ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್.
ನಮಸ್ತೆ ಸರ್.
ನಮಸ್ತೆ ಸರ್. ನಮ್ ಪ್ರೆಸಿಡೆಂಟ್ ಇದ್ದಾರೆ.
ಇಲ್ಲ ನಮಸ್ತೆ ಸರ್. ಚಿನಿವಾಲನ್ ಸರ್ ನಮಸ್ತೆ ಸರ್.
ಕಾಗಲ್ಗಾರ್.
ಹಾ ಸರ್, ಹೇಳಿ ಸರ್.
You have taken the very good subject because on 19th we are observing a World Liver Day.
Yes sir, yes sir.
On 19th
Yes
of
sir.
April we are observing a World Liver Day. You have chosen the very correct topic today.
Thank you sir, thank you. ಇದು ಲಾಸ್ಟ್ ಮಂತ್ ಮಾಡ್ಬೇಕಾಗಿತ್ತು ಸರ್, ಸ್ವಲ್ಪ ಡಿಲೇ ಆಯ್ತು.
Delay is also good because on 19th we are observing World Liver Day.
Yes sir, yes sir, yes sir. Thank you sir. It's optimum time. Dr. Mahesh. ಇದೀರಾ ಸರ್? ಓಕೆ ಸರ್. ಚಿನ್ವಾಲ್ ಸರ್, ಸ್ಟಾರ್ಟ್ ಮಾಡೋಣ ಸರ್.
ಸ್ಟಾರ್ಟ್ ಮಾಡ್ರಿ.
Good evening everyone. On the behalf of IMA Public Health Subcommittee, as a routine program, every month we are organizing one different CME with a different speaker with the interested topic. So today we have chosen one important and innovative something related to the liver failure. So something related to liver. So we have chosen a good speaker, Dr. Mahesh Gop Shetty from the Bangalore. He has come. Sir, welcome Dr. Mahesh Gop Shetty sir. And he is going to deliver important today's topic, that is how to prevent the liver failure. We have already a lot of theory and lot of practical and a lot of clinical knowledge we have got regarding the liver failure, but how to prevent, what is the different techniques? So like a kidney, how we are having some dialysis or something like, is there any other preventive measures? So that sir is going to highlight. Second, I welcome Dr. Ravindra sir from Bangalore. And sir, welcome for today's function sir.
Namaste,
and
sir.
also I welcome all our senior members and senior office bearers and the past president and past chairman of the IMA KSP for today's function. And also I welcome all our subcommittee members, public health subcommittee members for today's function. Now I hand over to the Dr.
I will briefly tell about this thing, sir. Yeah.
Jayalakshmi madam, idira? I am a prayer. Before Ravindra sir, 1 minute.
Yes,
there is
sir.
a protocol is there, sir.
Yeah.
So in that protocol, I am going to call Dr. Jayalakshmi for IMA prayer.
Okay, sir.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ.
Yeah, Rajalakshmi madam.
ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರಿಗೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಥ್ಯಾಂಕ್ ಯು ಸರ್.
Thank you madam. Now I call upon Dr. Adarsh to give regarding the flag salutation of our IMA. Dr. Adarsh.
Hello.
Yeah, Dr. Adarsh.
ಹೇಳಿ ಸರ್.
Good.
Go ahead, sir.
ಅವ್ರ ಹತ್ರ ಇಲ್ಲ, ನೀವೇ ಹೇಳ್ಬಿಡ್ರಿ ಕಾಗಲ್ಕರ್.
ಹೇಳಿ ಸರ್.
ನೀವು ಹೇಳ್ಬಿಡ್ರಿ.
ಗ್ಯಾಪ್ ಇರಬಾರ್ದು ಅದಕ್ಕೆ. ಮೊದಲೇ ಹೇಳ್ಬೇಕು ಅವ್ರಿಗೆ.
ಹೇಳಿದ್ದೀನಿ.
ಹೇಳ್ರಿ, ಯು ಕಂಟಿನ್ಯೂ. ಇಫ್ ಯು ಹ್ಯಾವ್ ದಟ್ ಇದು ಯು ಕ್ಯಾನ್ ಗೋ ಹೆಡ್. ಕೇಳ್ರಿ ಅವ್ರು
ಸರ್, ಇಫ್ ದೇರ್ ಇಸ್ ಎನಿ ಡಿಫಿಕಲ್ಟಿ ನಾನೇ ಹೇಳ್ಬಿಡ್ತೀನಿ ಸರ್.
ಹೇಳಿ ರಾಜೇಂದ್ರ ಪ್ರಸಾದ್, ಗೋ ಹೆಡ್.
ಹೇಳ್ಬಿಡ್ರಿ.
ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯುವಾಗಿರಲಿ. ಥ್ಯಾಂಕ್ ಯು.
Thank you, Rajan sir. Thank you. Now I call upon our beloved President of IMA KSP, Dr. Chinivalan sir, to give a few words regarding this today's program. Dr. Chinivalan sir.
ಎಸ್,
Please sir.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಇಂದಿನ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಫೋರಂ ಕಡೆಯಿಂದ ಈ ಒಂದು ವೆಬಿನಾರ್ ಅನ್ನು ಅರೇಂಜ್ಮೆಂಟ್ ಮಾಡಿದಂತಹ ಡಾಕ್ಟರ್ ಸುರೇಶ್ ಮಾಜಿ ಅಧ್ಯಕ್ಷರಾದ ಬಿ ಬಿಡನಾಳ್ ಅವರೇ, ರಾಜೇಂದ್ರ ಪ್ರಸಾದ್, ಡಾಕ್ಟರ್ ಆದರ್ಶ್ ಮತ್ತು ಸೇರಿದ ಎಲ್ಲ ಮತ್ತು ಇಂದಿನ ಉಪನ್ಯಾಸಕರಾದಂತಹ ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಗೋಪಶೆಟ್ಟಿ ಮತ್ತು ಮಾಡರೇಟರ್ ಆದಂತಹ ರವೀಂದ್ರ ಅವರಿಗೆ ಎಲ್ಲರಿಗೂ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯದ ಪರವಾಗಿ ಸ್ವಾಗತ ಕೋರುತ್ತಾ, ಈ ಒಂದು ದಿನಕ್ಕೆ ಈ ವೆಬಿನಾರ್ಗೆ ಸುರೇಶ್ ಕಾಗಲಕರ್ ಅವರು ಒಳ್ಳೆಯ ಒಂದು ಟಾಪಿಕ್ ಅನ್ನು ಆರಿಸಿಕೊಂಡಿದ್ದಾರೆ. ಯಾಕಂದರೆ ಇತ್ತೀಚೆಗೆ ಸಣ್ಣ ಸಣ್ಣ ವಯಸ್ಸಿನ ಹುಡುಗರು ಸಹ ಲಿವರ್ ಫೇಲಿಯರ್ದಲ್ಲಿ ಮದ್ಯಪಾನದಿಂದ ಬಹಳಷ್ಟು ಕೇಸ್ಗಳು ನಾವು ನೋಡ್ತಾ ಇದ್ದೀವಿ ನಮ್ಮ ದಿನನಿತ್ಯದಲ್ಲಿ. ಸೊ ಇಂತಹ ಸಮಯದಲ್ಲಿ ಅಂತಹ ಕೇಸುಗಳಿಗೆ ಯಾವ ರೀತಿಯ ಒಂದು ಚಿಕಿತ್ಸೆ ನೀಡಬೇಕು, ಯಾವ ರೀತಿ ಲಿವರ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟನ್ನು ಬಿಟ್ಟು ಕೇವಲ ಔಷಧ ಮಾತ್ರೆಯಿಂದ ಚಿಕಿತ್ಸೆ ಮಾಡಬಹುದು ಎಂಬ ಒಂದು ಇದರ ಬಗ್ಗೆ ನಮ್ಮ ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಗೋಪಶೆಟ್ಟಿ ಅವರು ತಿಳಿಸಿಕೊಡ್ತಾರೆ ಅಂತ ಹೇಳಿ ಅವರಿಗೂ ಮತ್ತು ಎಲ್ಲರಿಗೂ ವಂದನೆಗಳನ್ನು ತಿಳಿಸುತ್ತಾ ನಾನು 2 ಮಾತುಗಳನ್ನು ಮುಗಿಸ್ತಾ ಇದ್ದೇನೆ.
Thank you, Chinivalan sir, for your kind words, sir. And now, Dr. Rajan sir, please go ahead the further program, sir. Dr. Rajan Prasad sir.
Sir, introduction of Dr. Ravindra.
Brief I ಹೇಳ್ಬಿಡಿ sir.
ಎಲ್ಲ ನೀವೇ ಇಂಟ್ರೊಡ್ಯೂಸ್ ಮಾಡ್ಬಿಡಿ ಸರ್.
Now we have got our the famous gastroenterologist from the Bangalore, Dr. Ravindra sir is here, and he is going to be as a moderator, and under his banner there is one speaker, and we have got a good important topic. Sir is going to proceed. Dr. Ravindra sir, please carry on.
Yes. I think basically ಈಗ ಎಲ್ಲರೂ ನಾವು ಚಿನಿವಾಲರ್ ಸರ್ ಮಾತಾಡಿದ್ರು, ಡಾಕ್ಟರ್ ಸುರೇಶ್ ಅವರು ಮಾತಾಡಿದ್ದಾರೆ. ಈಗ ನಮ್ಮ ಇದರಲ್ಲಿ ಮೋಸ್ಟ್ ಕಾಮನ್ ಆಗಿ ನಾವೇನ್ ಮಾಡ್ತೀವಿ, ಡಯಾಬಿಟಿಸ್, BP ಮತ್ತೆ ಹಾರ್ಟ್ ಡಿಸೀಸ್ಗೆ ಬಹಳಷ್ಟು ನಾವು ಇಂಪಾರ್ಟೆನ್ಸ್ ಕೊಡ್ತಾ ಇರ್ತೀವಿ. ಬಟ್ ಏನಂದ್ರೆ ಈಗ ಕಾಮನೆಸ್ಟ್ ಡಿಸೀಸ್ ಇಂಡಿಯಾದಲ್ಲಿ 100ರಲ್ಲಿ 40% ಜನಕ್ಕೆ ಫ್ಯಾಟಿ ಲಿವರ್ ಬಂದಿದೆ. ಆ ಫ್ಯಾಟಿ ಲಿವರ್ ಇಂದ ಯಾರು ಫ್ಯಾಟಿ ಲಿವರ್ ಅಂದ್ರೆ ನಾವು ಮೊದ್ಲೇನು ಚಿಂತನೆ ಮಾಡ್ತಾ ಇರ್ಲಿಲ್ಲ. ನಾವು ಫ್ಯಾಟಿ ಲಿವರ್ ಹ್ಯಾಸ್ ಬಿಕಮ್ ಎ ಎಪಿಡೆಮಿಕ್. ಅದರಿಂದ ಇಂಡಿಯನ್ ಗೌರ್ಮೆಂಟ್ ಹ್ಯಾಸ್ ಮೇಡ್ ಇಟ್ ಆಸ್ ಇಟ್ ಇಸ್ ಎ ಕಮ್ಯುನಿಕೇಬಲ್ ಡಿಸೀಸ್ ಅಂತ ಮಾಡಿದ್ದಾರೆ ಈಗ. ಅದೇ ರೀತಿ ನಮ್ಮಲ್ಲಿ ಹೆಪಟೈಟಿಸ್ B, ಹೆಪಟೈಟಿಸ್ C ಮತ್ತೆ ಆಟೋ ಇಮ್ಯೂನ್ ಲಿವರ್ ಡಿಸೀಸ್ ಮತ್ತೆ ಮೆಡಿಸಿನ್ಸ್ ಸಹಿತ ತಗೊಂಡಾಗ್ಲು ಅಂದ್ರೆ ಪ್ಯಾರಾಸಿಟಮಾಲ್ ಜಾಸ್ತಿ ತಗೊಳ್ಳೋದು, ಆಂಟಿಬಯೋಟಿಕ್ ತಗೊಳ್ಳೋದು, ಅದರಿಂದನೂ ಲಿವರ್ ಡಿಸೀಸ್ ಬರ್ತಾ ಇದೆ. ಇದಲ್ಲದೆ ಲೇಡೀಸ್ ನಲ್ಲಿ ಆಟೋ ಇಮ್ಯೂನ್ ಡಿಸೀಸ್ ಮತ್ತೆ ಕಾಪರ್, ಅಂದ್ರೆ ಬೇಸಿಕಲಿ ಈ 4 ಡಿಸೀಸಸ್ ನಮ್ಗೆ ಲಿವರ್ಗೆ ತೊಂದರೆ ಕೊಡ್ತಾ ಇದೆ. ಒಂದು ಫ್ಯಾಟಿ ಲಿವರ್ ಡಿಸೀಸ್, ಸೆಕೆಂಡ್ ಹೆಪಟೈಟಿಸ್ B ಮತ್ತೆ ಹೆಪಟೈಟಿಸ್ C, ಮೂರನೇದಾಗಿ ಆಲ್ಕೋಹಾಲ್, ನಾಲ್ಕನೇದಾಗಿ ನಮ್ಗೆ ಈ ಮೆಡಿಸಿನ್ಸ್ ನಿಂದ ಆಗ್ತಕ್ಕಂಥದ್ದು, ಎಸ್ಪೆಷಲಿ ನಾವು ಪ್ಯಾರಾಸಿಟಮಾಲ್ ಕನ್ಸ್ಯೂಮ್ ಮಾಡೋದು, ಪೇನ್ ಕಿಲ್ಲರ್ ಕನ್ಸ್ಯೂಮ್ ಮಾಡೋದು, ಆಮೇಲೆ ಕೆಲವು ಸಲ AKT ಮೆಡಿಸಿನ್ಸ್ ಇಂದ ಆಗುತ್ತೆ. ಇದೆಲ್ಲ ಕಾರಣಗಳಿಂದ ನಮ್ಗೆ ಲಿವರ್ ಪ್ರಾಬ್ಲಮ್ಸ್ ಆಗುತ್ತೆ. ಕಾಮನ್ ಆಗಿ ಜಾಂಡಿಸ್ ಬರುತ್ತೆ, ಕೆಲವ್ರಿಗೆ ದೇ ವಿಲ್ ಎಂಡ್ ಅಪ್ ವಿತ್ ಲಿವರ್ ಫೇಲ್ಯೂರ್, ಮತ್ತೆ ಕೆಲವ್ರಿಗೆ ಲಿವರ್ ಸಿರೋಸಿಸ್ ಆಗುತ್ತೆ. ಬೇಸಿಕಲಿ ದೀಸ್ ಆರ್ ದ 3 ಥಿಂಗ್ಸ್ ವಿ ಸಿ: ಫ್ಯಾಟಿ ಲಿವರ್, ಹೆಪಟೈಟಿಸ್, ಲಿವರ್ ಸಿರೋಸಿಸ್ ಅಂಡ್ ಲಿವರ್ ಫೇಲ್ಯೂರ್. ಒಮ್ಮೆ ಪೇಷಂಟ್ ಗೋಸ್ ಇನ್ ಟು ಲಿವರ್ ಫೇಲ್ಯೂರ್ ಅಂದ್ರೆ ಸಿರೋಸಿಸ್ ಬಂದ ಮೇಲೆ ನಮ್ಗೆ ದೇರ್ ಇಸ್ ನೋ ಟ್ರೀಟ್ಮೆಂಟ್ ಎಕ್ಸೆಪ್ಟ್ ಫಾರ್ ಲಿವರ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್. ಬಟ್ ಈಗ ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಏನ್ ಇವತ್ ಮಾತಾಡ್ತಾ ಇದಾರೆ, ಇಷ್ಟು ವರ್ಷ ನಾವೇನ್ ಮಾಡ್ಬೇಕಾಗಿತ್ತು ಅಂತಂದ್ರೆ, ಹೆಪಟೈಟಿಸ್ ಇಂದ ಲಿವರ್ ಫೇಲ್ಯೂರ್ ಆಯ್ತಂದ್ರೆ, ಅಥವಾ ಆಲ್ಕೋಹಾಲ್ ಇಂದ ಲಿವರ್ ಫೇಲ್ಯೂರ್ ಆಯ್ತಂದ್ರೆ, ಅಥವಾ ಫ್ಯಾಟಿ ಲಿವರ್ ಇಂದ ಲಿವರ್ ಫೇಲ್ಯೂರ್ ಆಯ್ತಂತಂದ್ರೆ ಓನ್ಲಿ ಆಪ್ಷನ್ ಏನಿತ್ತಪ್ಪ ಅಂದ್ರೆ ಲಿವರ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಇತ್ತು. ಲಿವರ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಆದ್ರೆ ನಮ್ಗೇನು, ವಿ ಹ್ಯಾವ್ ಟು ಸ್ಪೆಂಡ್ 20-30 lakhs ಸ್ಪೆಂಡ್ ಮಾಡಬೇಕು. ಅದಾದ್ಮೇಲೆ ಸಹಿತನು ಮೆಡಿಸಿನ್ಸ್ ನಾವು ಬಹಳ ಕಂಟಿನ್ಯೂ ಮಾಡಬೇಕು. ಫಸ್ಟ್ ಟೈಮ್ ಇನ್ ದ ಕಂಟ್ರಿ, ಪ್ರಾಬಬ್ಲಿ ಫಸ್ಟ್ ಟೈಮ್ ಇನ್ ದ ಅವರ್ ಹಿಸ್ಟ್ರಿ, ನಮ್ಮ ಒಬ್ಬ ಕರ್ನಾಟಕದ ಡಾಕ್ಟರ್ ಆಗಿರ್ತಕ್ಕಂಥ ಮಹೇಶ್ ಅವರು ಲಿವರ್ ಡಯಾಲಿಸಿಸ್ ಅನ್ನೋದನ್ನ ಇಂಡಿಯನ್ ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ ಆಫ್ ಸೈನ್ಸ್ ಮೂಲಕ ಇದನ್ನ ಡೆವಲಪ್ ಮಾಡಿದ್ದಾರೆ. ಅದನ್ನ ನಾವು ಅಕ್ರಾಸ್ ದ ಕಂಟ್ರಿ ಎಲ್ಲ ಕಡೆನೂ ಇದನ್ನ ಸ್ಟಾರ್ಟ್ ಮಾಡಿದೀವಿ ಯೂಸ್ ಮಾಡ್ಲಿಕ್ಕೆ. ಅದೀಗ ಪ್ರೈಮರಿ ಟ್ರಯಲ್ ಅಂದ್ರೆ ಹ್ಯೂಮನ್ ಟ್ರಯಲ್ಗೆ ಸ್ಟಾರ್ಟ್ ಆಗಿದೆ. ಅದರಲ್ಲಿ ನಾವು ಈ ಒಂದು ಲಿವರ್ ಡಯಾಲಿಸಿಸ್ ನಾವು ಮಾಡಿದ್ರೆ ಬಹಳಷ್ಟು ಜನಕ್ಕೆ ಏನಾಗಿದೆ, ಆ ಲಿವರ್ ಫೇಲ್ಯೂರು ರಿವರ್ಸ್ ಆಗಿ ಲಿವರ್ ರೀಜನರೇಟ್ ಆಗಿ ವಿತೌಟ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ಸಕ್ಸಸ್ಫುಲ್ ಆಗುತ್ತೆ ಅನ್ನೋ ಒಂದು ಪ್ರಯತ್ನ ನಡೀತಾ ಇದೆ. ಅದಕ್ಕೋಸ್ಕರ ಈ ಎಲ್ಲ ನಮ್ಮ ಆಲ್ ಡಾಕ್ಟರ್ಸ್ಗೆ ಇದೊಂದು ಲಿವರ್ ರೀಜನರೇಷನ್ ಮೆಷಿನ್ ಅದು ಬಂದಿದೆ. ಆಲ್ರೆಡಿ ಅವರು ರ್ಯಾಟ್ ನಲ್ಲಿ ಇದನ್ನ ಡಯಾಲಿಸಿಸ್ ಮಾಡಿ ಆ ರ್ಯಾಟ್ಸ್ ಲಿವರ್ ಗ್ರೋ ಆಗಿದೆ. ಈ ತರ ಮಾಡ್ತಂದ್ರೆ ಇಟ್ ವಿಲ್ ಬಿ ಎ ಬಿಗ್ ಚೇಂಜ್ ಇನ್ ದ ಫೀಲ್ಡ್ ಆಫ್ ಮೆಡಿಸಿನ್. ಲಿವರ್ ಡಯಾಲಿಸಿಸ್ ಮಾಡಿ ಲಿವರ್ ರೀಜನರೇಟ್ ಆಯ್ತಂದ್ರೆ ಲಿವರ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ ನ ಸಹಿತ ನಾವು ಅವಾಯ್ಡ್ ಮಾಡಬಹುದು. ಐ ಥಿಂಕ್ ದ ಹೋಲ್ ಐಡಿಯಾ ಈಸ್ without liver transplant, this new thing which he is going to do is going to make a change in the management of liver failure and liver cirrhosis. Now I will request Dr. Mahesh to speak on how to manage, how to prevent this liver failure, and then is there any alternative apart from liver transplant, any new thing which he has developed for preventing without liver transplant? Can we do away with this liver dialysis what you have already started doing in Karnataka and all over India? Now I will request Dr. Mahesh to speak to this august audience about this new modality of treatment of liver dialysis and avoiding liver transplant, and which, if it is going to be successful, it will be a big game changer in medicine.
Dr. Suresh, you are muted.
Yeah, sorry for interruption, sir. Ravindra sir.
Yes, sir.
Regarding Dr. Mahesh Gopshetty, sir, brief introduction will be given by Dr. Rajan Prasad, sir.
Yes, sir. Yes, sir.
Rajan Prasad, sir, brief introduction.
Sir, introduction.
I will only do, sir. I will do.
Yes, sir. Yes, sir.
Oh, okay. Okay.
Yes, sir. Dr. Mahesh Gopshetty is a very well-known liver transplant surgeon in Karnataka. And then he is one of the pioneer liver transplant surgeons in Karnataka. He started in Apollo Hospital, which they started liver transplant, and they have done more than 1,000 liver transplants. And he has done pancreatic transplants. Most important thing is he has done small intestine transplant also. That is his area of domain. And then he has been trained in America. And then small intestine transplant, liver transplant, kidney transplant, pancreas transplant. Basically, multi-organ transplant he is doing. And he is from North Karnataka. And then he is doing extreme good job in our state. And I request Dr. Mahesh to address to this august audience about this is more than this. See, everybody will do liver transplant, but he is trying to do a help that without liver transplant, he is finding this machine with Indian Institute of Science. If this is a successful, even liver transplant will be avoided in some cases. That is what is the new thing which he is going to tell to us today. Now, over to you, Dr. Mahesh.
Thank you, sir. Sir, ಇದು ನಂದು ಸ್ಕ್ರೀನ್ ಕಾಣ್ತಾ ಇದೆಯಾ ಸರ್? ಸ್ಲೈಡ್ಸ್ ಎಲ್ಲ ಕಾಣ್ತಾ ಇದೆಯಾ?
ಒಂದೇ ನಿಮಿಷ. ಬರ್ತಾ ಇದೆ.
Good evening, sir. Thank you. And I've been working on this for last 10 years, in collaboration with IISc. We have managed, I have developed this something similar to a dialysis machine, but for liver failure patients. Dialysis, it uses only a filter, whereas in liver systems, we use combination of cells that are normally found in the liver, like hepatocytes and endothelial cells in this system, and I will explain, what it does and how it is different. Basically, we have got approval. Initially, we had approval for trying out our device in acute liver failure patients. About a month ago, we have got approval to conduct our clinical trials and try this machine even in patients suffering from acute and chronic liver failure. So So, what is this acute liver failure? Let me just introduce this topic. Acute liver failure happens in a patient with normal liver, whereas ACLF, acute component or the acute failure happens in patients who already have developed cirrhosis. I'll just concentrate on ALF first, and then I will go on to the ACLF patients. So like I said, acute liver failure patients, the background liver is normal. They are exposed to a sudden insult like a viral infection, drugs, or sometimes, we don't know the etiology. And all of a sudden, more than 80-90% of the liver gets damaged in a very short span of time, say in about a month or month and a half. Because these patients don't have any other collaterals, these patients tend to accumulate a lot of toxins in the body. These toxins irritate the brain and cause cerebral edema. These patients also develop in the late stages leaky gut and sepsis. So here the killer is the cerebral edema in majority of the patients. These patients cannot afford to wait long. Before the edema becomes too much and stops the blood supply to the brain itself, we need to do a liver transplant for these patients so that the edema comes down, the toxins are cleared, and patients can survive. In patients who take ratol poisoning, people have tried plasma exchange, and we have been successful in treating a small percentage of these patients without need for liver transplant. Like I said, liver transplant is a must for them in a short span of time. And if you don't do it, then they die. And the death is seen in more than 70% of these ALF patients who don't undergo liver transplant. What our device does in this scenario is we should be able to purchase something off the shelf. And whenever that machine is connected, it should start working right away. And that is the pretext, over which we have developed our device. The people will be able to take the device off the shelf and use it in these patients. And obviously, the machine should be costing less than what people spend for transplant. ACLF, like I said, background liver is already cirrhotic. They get exposed to a certain insult, and these patients' body is not able to tolerate that extra challenge. So the precipitating cause why these patients develop acute liver ACLF is patients who go on binge drinking alcohol. Patients may develop either infection in the liver or outside the liver, like cellulitis. These infections which are not native to the liver, anywhere else in the body, they throw a certain metabolic challenge to these patients. These patients already have a suboptimal liver, and this extra burden it is not able to handle. And these patients develop ACLF. And even GI bleed can precipitate ACLF episode. These patients, most of them succumb to sepsis or multi-organ failure. In these patients, people have tried plasma exchange, but again, the success is not very good, and plasma exchange can buy some time so that patients undergo transplant in a short span of time. If we miss this window of opportunity in these patients, then death is certain. Death is seen in ACLF patients anywhere between 20 to 80% of these patients, based on the number of organ failures that we see. So alternatives to liver transplant that people have tried so far is, people have tried to decellularize organs from the animals or, other humans. So they take out all the native cells and endothelial cells, cholangiocytes, and repopulate it with human or the patient's hepatocytes and endothelial cells. These organs have not really functioned well even in animal trials, because it is difficult to grow endothelial cells inside the blood vessels. And if the blood vessels are not lined with endothelial cells, these patients, when it is implanted, the whole graft itself tends to get clotted. And when the graft gets clotted, obviously it will not be able to work. So I don't think technology is mature enough right now for us to promote decellularization and repopulating the organ with human hepatocytes and endothelial cells. People have also tried to grow hepatocytes on a matrix, and that is like a piece of mesh. And they have tried to put this mesh into the subcutaneous or the preperitoneal space in animals. But the problem with this technology is it requires new blood vessels to grow into the matrix, And patients with acute liver failure, they just don't have this kind of time. And when the new blood vessels grow and these hepatocytes are not of the patient's own origin, they are recognized as foreign and they get destroyed in a short span of time. And again, this is not a very good technology. People have tried to put hepatocytes into the portal vein, spleen, peritoneum, or any body orifice that we can think of. Again, problem with putting these hepatocytes into portal vein is these cells can escape the liver, they can enter into pulmonary circulation, cause pulmonary embolism, cardiopulmonary compromise, and these cells will be recognized as foreign and they get destroyed in a very short span of time. And there is no way to monitor if the hepatocytes that we have put into the patients, whether they are working or not. So the basic principle in ALF patients is that whatever we connect to the patient, it should start working right away. And if it does not, then these patients, cerebral edema worsens and they succumb. Like I explained, problem with hepatocyte transplant into the portal vein is that sometimes portal vein itself can get clogged. These cells are big enough and they can get trapped in the lung vasculature and cause embolism and cardiopulmonary compromise, and these cells will get destroyed over a period of time. In the past, people have tried, developing bioartificial liver systems, but none of them have really been successful. And what you can see on the screen is the number of devices that people have tried in the past. And you can see that most of these devices use porcine origin hepatocytes or tumor origin hepatocytes. And there are devices that you would have heard about like Mars, Prometheus, and SPAD. These devices, they don't use any biological cells. They use some kind of anion absorption technique where the toxins are absorbed into this resin. And once the toxins are taken out, the belief is that the milieu in the patient becomes favorable for the hepatocytes to multiply and repopulate the whole organ. But again, these have not been successful. You can see in the photograph, this is how complex Mars and Prometheus and the SPAD machines are. And because it is so complex, the acceptance in the medical fraternity is not very good. And also, it has not really shown any survival benefit. So I will just go into the details about other liver support systems that we have tried. One is the ELAD, that is extracorporeal liver assist device. This was developed somewhere in 1990s. And this device used HepG2 tumor cells. And when you use tumor cells themselves, there is always the concern that the cancer cells can escape into the circulation. They can develop into tumor in the recipient himself. So this device was tried out on 11 patients. You can see that one was alive, 4 were transplanted, and rest of the patients just did not survive. And the same story keeps on repeating. Even HepAssist device, this was developed in 2004. This is one device that has undergone randomized control trials. And again, this device did not really show any survival benefit. 30-day survival with the bioartificial liver system was 71% and the controls were 62%. So their patient selection probably was not the best one. And another device was modular extracorporeal liver support system. Initially, this device used porcine hepatocytes. Later on, they changed their porcine hepatocytes into human hepatocytes. And this device is so complex that it uses two modules, one a dialysis machine and a cell module in parallel. And because it is so complex, again, it did not really work well, and the acceptance in the medical fraternity was not that great. Another device that people have tried is called as AMC, or the Amsterdam Medical Center Bioartificial Liver System. This again uses porcine cells. This was tried out in 12 ALF patients. 11 were bridged to transplant, and here the goal was they were not able to achieve that. Patients would survive with the help of their system alone without the liver transplant. All these devices, even I will tell you a little more about about the devices, other devices, but in all of these devices, the same theme continues. All of them showed to be safe, and most of them resulted in improvement in clinical and or biochemical parameters, but none of them were able to show any survival benefit in these patients. There is one Chinese hybrid BAL system. Again, I'm not going to bore you with too many of these details. I will just skip all these because the same story keeps on repeating again and again. The device, I learned a lot of lessons from these devices, and we try to do something different so that we get a different kind of result. So how is our device different from other devices? The name of our device is called as EBDLR, that is extracorporeal bioengineered dual cell liver regeneration system. Dual cell because we use two types of cells, that is hepatocytes and endothelial cells. That is how we differ from other devices. I will just tell you a little. How did we come up with this idea? Why use multiple cell lines? For any community to be successful, we need all kinds of people to be living together in a cohesive manner. If you put only doctors in one kind of apartment complex, they will not be able to thrive. We will need a cleaner, we will need a plumber, we will need electrician, we will need cleaners. Any kind of blue color, pink color, white color, collared people for any community to survive and thrive well. So apart from hepatocytes, what is the other type of cell that is quite common in the liver is endothelial cells. So that's how we decided to use two cells. And even before this, we did try to use other types of cells in our device. In a Petri dish experiment, we did use mesenchymal stem cells, other cells that are commonly seen in the liver, but adding more cells did not translate into better survival or better functioning of these cells. Hence, we decided to stick to hepatocytes and endothelial cells co-cultured together. They are grown in a very specific manner. It kind of mimics the sinusoidal structure, and that is what we thought will help our patients. We use human origin cells in our device. And these are normal cells that we purchase from a company called ATCC. They provide us with the pharma grade normal human hepatocytes and endothelial cells. These cells are tweaked in the lab so that they function better and they multiply to a number that we want them to multiply. These are immortalized using a vector called as SV40. And we decided to use about 1 billion cells per kilogram. So based on the thickness and the weight of the patient, we should be able to scale it up or scale it down depending on the need. And other devices, there was always some barrier between the cells that they had grown and the plasma that circulated with these cells. Whereas our device, we decided to make sure that the plasma actually comes in contact with both hepatocytes and endothelial cells so that the detoxification is much better. Our company that we formed, which is incubated at IISc is called as Yukruta Life Sciences. Yukruta is a Sanskrit term for liver. And these are all the team members that have worked on this relentlessly for about 10 years for us to have come through this so far. Like I said, we tried various combination of cells commonly present in the liver, but the best results were observed when we co-cultured hepatocytes and endothelial cells. Adding additional cells that are normally present in the liver did not give us any extra added advantage. I would like to bring your attention to the blue and the red color graphs here. The first graph that you see is on day 1, and the last graph that you see is day 7. The blue and the red color are human hepatocytes that are grown in a Petri dish, whereas the green and the purple one are hepatocytes and endothelial cells co-cultured together. You can see on day 1, the co-cultured cells are a little less. That's how many of cells that we put in initially. 1 week down the line, you can see that the monolayers, that is hepatocytes and hepatocytes alone, they kind of diminished in number. They were not able to survive long, even for about a week. Whereas cells that together, that is hepatocytes and endothelial cells, they tend to survive better, they tend to function better, and they tend to live longer. when we grow these cells together, we believe that there is some kind of communication that happens between the hepatocytes and endothelial cells, and they support each other so that they function better and survive longer. And you can also see that glucose utilization, albumin production, lactate utilization, and ammonia detoxification was far better in cells that were co-cultured together than monolayer cells alone. The entire setup in our device is very similar to dialysis, where a dual lumen catheter is placed inside the patient, and blood is drawn out from the patient. It passes through a filter that separates plasma and the other cells. The separated plasma in turn gets circulated with the cells that are grown in an incubator. The horizontal blue colored lines that you see is actually an incubator where the cells are housed. The plasma itself gets circulated with these cells, and the purified plasma is given back to the patient. Cells will continue to remain in the incubator, in the bioreactor. Cells will not go back to the patient. Only the purified plasma goes back to the patient. There are a lot of sensors that are built in. There are a lot of filters that are placed in so that even though some cells may get dislodged, those dislodged cells don't get back to the patient himself. So, the blue color box that you see is the incubator, and the gray color box is what we created, that had a lot of sensors and reservoirs. This was the first version of the device that we built. And, the second version of the device looks much more sleeker. I will show you some photographs as we go along. The blue color box is an incubator that we purchased off the shelf. That's commercially available. And inside this incubator, we housed our cells. This is the second version of the device that will be rolled out onto the patient's bedside. The lower half of the device has an incubator that is built in. The upper part has the sensors and the electronic components as well. This is what you see, the serpentine channel that you see in the cartridge. This forms the heart of our device. This is what we call as like a bioreactor or the cartridge. The channel that you see, there is a counter channel on the opposite side as well. So there are two channels on one membrane. On one side, we grow the hepatocytes. On the opposite side, we grow the endothelial cells. So they kind of mimic the sinusoidal structure that is normally present in the liver. And the plasma itself gets circulated with both the hepatocytes and the endothelial cells. The purified plasma is given back to the patient. Initially, we tried connecting the empty shell of the device to a rabbit model. And these rabbits, let me remind you, were healthy rabbits, and the machine itself was like an empty shell. We wanted to see if there were any biochemical or physiological changes when a healthy animal is connected to our device. And you can see here that the physiological and the biochemical parameters did not vary too much. Once we were certain that there were no adverse events in a healthy animal, we went on to induce acute liver failure in the rabbits, and then we started connecting our device. So we use the chemical called as D-galactosamine. We give a dose of this to the rabbit, wait for about 16 to 24 hours, check the biochemistry, make sure that the ALF has set in, do a clinical examination, and then, after we are certain that the acute liver failure has set in, we start connecting our device. And each session, we were able to salvage these animals using our device. Each animal would be connected roughly about 2 or 3 sessions in a week. That is like alternate days. And each session would last for about 4 to 6 hours. And that, 3 sessions were more than enough to recover all these animals. These animals were allowed to live for about 30 days. And at the end of 30 days, these animals were sacrificed. I would like to bring your attention to the first graph here. The top line, the red dots, those were the ALF animals that were connected to our device. Those dots that you see were the acute liver failure animals that were not connected to the device. And you can see the stark difference in survival. Device connected animals and the animals that were not connected to the device. So the survival, with the help of a device was quite phenomenal. And we were able to show that the animals that recovered had their liver architecture restored to normal, and it looked absolutely like a normal liver. Animals that died because of acute liver failure, we saw that there was massive necrosis of the hepatocytes. We used about 5 billion cells, as the rabbits weighed about 5 kg. And in rabbits, the hepatocytes and the endothelial cells that we used were of rabbit origin, and these were available in a commercially, and we were able to salvage these animals. I will tell you why we used why I stress on this commercially available in the subsequent slides. After we were successful in salvaging rabbits, we wanted to check the efficacy of our device in bigger animal model. So we used a Yorkshire pig model. These Yorkshire pigs weigh about 60 to 70 kilos, almost as much as a human adult. And we did our experimentation at a center called Palamur Biosciences. This is somewhere close to Hyderabad. This is a fantastic facility, and we did our experiments using a GLP format. GLP format is where apply to the committee with a proper protocol, and once the protocol gets approved, there is no room for any modifications or changes to be made in the protocol. And these studies are all tightly audited and recorded. And even in this much stringent, strict manner done test, we were able to show our efficacy of our device to be very good. We standardized our failure model in the pigs. Once we were successful there, we started connecting our device to these ALF animals in the pig. Again, the chemical used was D-galactosamine here, the same chemical that we used in rabbits. The first graph that you see, there are different colored lines that you see. Each color represents a different animal. The red color was the control, and the other animals were connected to the device. You can see and control animal dies within 2-3 days, whereas other animals that were connected to our device, of them went on to survive and they were all sacrificed about a month down the line after their recovery, and their liver showed excellent regeneration. After we tested it in chemically induced liver failure model, we wanted to check the efficacy in a surgically induced liver failure model. So how did we create this surgical liver failure model is, but we knock out about 90% of the liver by doing surgery. So we do a 90% hepatectomy in these pigs. And these animals were connected to the device. And the animal that was connected to the device did survive. I will show you some slides here. The third photograph that you see is the 90% hepatectomy specimen. You can see that it weighs about 603 grams. That's a healthy liver that we have removed, 90%. That means, about 50 or 60 grams of the liver that would have been left behind in the pig, that has grown back with the help of our device to about 516 grams, in about 4 weeks' time. So we did see excellent regeneration in the native liver, even in the 90% hepatectomy model. This is the same biochemical parameters in the surgical model. And in porcine origin hepatocytes were easily available in a commercial manner, whereas porcine origin endothelial cells were not available commercially. So in these pig models, we used human origin hepatocytes and endothelial cells. Trying to recreate our own endothelial cells of porcine origin would end up taking a lot of our financial resources and a lot of our time. So we did not want to do that. We said, if pig cells can work in humans, human cells can work in pigs as well. That's why we decided to go with human origin hepatocytes and endothelial cells, even in these pig experiments. Like I said, we used Yorkshire pigs, and each of these pigs weighed about 60 to 70 kilos, almost as much as an adult human. And these are photographs showing that how we connected our device to the pigs. In animals, we will not be able to give too much anesthesia. If the animal feels well enough, it wants to move around, and it will not want to be restrained. And if we give too much anesthesia, the anesthesia itself may be detrimental to these pigs. And so we had to modify the cage, where the animals were restricted physically. What we saw was that before the session starts, the animal would be lethargic. It would not want to stand up. You give it food and water, it would not want to drink. And as each session was getting over, in the pigs, each session lasted for about 6 hours, and closer to the fifth and the sixth hour, animal would be feeling so much well that it would want to stand up and accept the feed and the water. So this was supposed to be a video, but I'm not able to play this video. And the same thing even in a surgical model, halfway through the sessions, the animal was feeling well enough for it to stand up, move around freely, eat and drink on its own. In the rabbit, because it was a small animal, we were able to use about 4 or 5 cartridges, and that was enough. Whereas in pigs, which weighed about 60, 70 kilos, we wanted to use 60 billion cells. For that, we had to modify our cartridge so that we can shrink the size of the bioreactor down. And we managed to put in about 16 layers of these cells together in one cartridge. And it was an engineering challenge. How do we keep these? The way the plasma flows is that each layer gets perfused with the plasma at the same time. The plasma does not go from layer 1 to 2 and 2 to 3 and 3 to 4, not that way. All layers, 16 layers, get the plasma all at the same time. And it was an engineering challenge which our engineers were able to overcome and create this shrunken cartridge which we were able to use successfully in pigs. With all these experimental data, we went to DGCA and CDSU. They were so excited with the animal results that they gave us permission to try our device in acute liver failure patients. So what are the inclusion criteria? There are 2 inclusion criteria for acute liver failure. One is a paracetamol overdose, other one is other etiologies. For paracetamol overdose, the lab parameters were quite strict. The bilirubin had to be less than 10, transaminases had to be more than 1000, INR more than 1.5, and creatinine less than 2. Whereas non-paracetamol overdose, these patients can have any bilirubin and any liver enzymes as long as they have INR more than 1.5, creatinine less than 2, and the clinician feels that these parameters are consistent with acute liver failure. That was enough for us to connect our device. So the patients had to be more than 18 years, less than 65 years. The family should be willing to give us the consent. Patients with any known or unknown etiology of ALF were good enough for our inclusion criteria. Only thing is INR had to be more than 1.5 and creatinine has to be less than 2. So like I said, ALF of paracetamol overdose, bilirubin had to be less than 10, transaminases had to be more than 1000. As long as they were able to maintain their hemodynamic parameters with minimal or modest amount of inotropes, that was also good enough for us. So what were the exclusion criteria in ALF patients? One is ALF patients, if they have cirrhosis, then they fall into the ACLF category. And I will explain about the ACLF category later on. And patients should not have massive cerebral edema. They should not have massive GI bleed. They should not have any hemodynamic instability. Pregnancy was the exclusion criteria. Patients with malignancy which was not controlled. Patients who did not want CPR or who had allergy to heparin, they were all excluded from this study. In ALF patients, we managed to connect it to 2 patients, and the first 2 patients that we connected were very much late into the ALF disease itself. They had roamed around in peripheral hospitals for about 4 or 5 days before they came to a metro city. And from the time they came to the metro city, the primary doctor tried his own standard of care for a day or 2. And when they were not successful, they wanted to try our device. Initially, in our enthusiasm, we said yes. In one particular patient, INR, which was more than 6, came down to about 2 with the help of our device, which was connected to this patient for a total of about 20-hour duration. The first session was for about 14 hours, and the second session was for about 6 hours. We did not see any significant adverse events, But again, these patients were so tired, they had exhausted their financial resources, and they just did not want to continue any treatment, and they wanted to go home. So we learned from these first two patients, and we said, we will not try our device in any patient with acute liver failure who's late into the disease process. We were waiting for these early disease ALF patients. But what we saw was that subsequently, we screened close to about 15, 20 patients. All the patients that we screened were very much advanced into the disease of ALF. And, the family comes to the metro town. They are ready to try our device. We say we will get our device. By the time we get our device ready and take it to the patient's bedside, patient would have deteriorated so badly that, any kind of treatment would be futile. So we were not able to connect our device to these subsequent 15 patients that we screened. This made us think, we wanted to complete our clinical trials. So we said, we went back to the CDSCO and the DGCA and requested them to give us approval for trying our device in ACLF patients, that is acute and chronic liver failure patients. ACLF patient, burden in the society is quite high. And we got this approval just about a week ago. With this new approval, we have to approach the same hospitals which had agreed to conduct our clinical trial in ALF. We are waiting for their ethics committee to approve this modified criteria. And once we get this, we will be able to connect our device in ACLF patients. So what are these inclusion criteria in ACLF? Again, the patient has to be between 18 to 70 years of age. The bilirubin should be more than 5. INR should be more than 1.5. Creatinine should be less than 2. And the bottom line is that these, patients should not have had any obvious decompensation or hospitalization in the preceding 1 month. These were the inclusion criteria that we have got approval from CDSCO to in ACLF patients. What are the exclusion criteria in ACLF patients? These patients who have uncontrolled sepsis, cardiopulmonary compromise, more than 3 organ failures at presentation, allergy to heparin, pregnancy, intracranial bleed, myocardial infarction. These are the exclusion criteria. In acute liver failure patients, our end goal was to see that, to see if the patient can survive with the help of our device, but without the need for liver transplant. Whereas in ACLF patients, I don't think we will be able to avoid liver transplant altogether. But if we can help these patients live long enough, they can survive long enough, then they probably can wait on the wait until they get a liver transplant done. Because these small group of ACLF patients, majority of them die. And if we can keep these patients alive for about a month or more, then they probably will recover and will get enough time to get the liver transplant done and go on to live a normal life. So the primary endpoint in these patients is, no adverse events. And secondary endpoint is 28-day mortality, change in endotoxin level, albumin function, change in individual organ, that is liver, kidney, respiratory, circulation, and coagulation, and the brain function. And to see if the patients who already have 1 or 2 organ failures, whether they will recover. These are all the secondary endpoints that we want to study. I will stop here. This is what I wanted to share, the kind of work that we have done. So I'll be happy to take any questions or any doubts you may have, sir.
Dr. Mahesh, I think it's a very new concept you have brought in. As a transplant surgeon, getting to this new concept is extremely a new innovative device what you have been doing now. And see, what is my question to you is, in the first 2 patients where you have tried in acute liver failure, apart from the INR, did they have improvement in encephalopathy, ammonia levels, and lactate levels and other things?
Sir, from the animal study, that what I can extrapolate is that we need at least 2 or 3 sessions for us to see any improvement, significant improvement in lactate and clinical improvement.
Okay.
1 session was not enough. So, I think if we can get an ideal patient where we try our device for at least 3 days, I'm
Okay.
quite sure we'll be able to see some benefits, sir. But
Okay.
one session alone is not enough.
Okay. But still you had one INR which came down from 6 to 2, I think.
Yes, sir. That was very encouraging. Lactate did improve a little bit, not significantly though, but we did not see much of clinical improvement.
Okay.
But I think we need at least 3 sessions for us to see if there is any clinical benefit, sir.
Okay. Now I will let the audience have any questions they can.
Yes, sir. I am Dr. Gurlingappa Bidal. Sir, you told the paracetamol is such a useful drug. Everybody, every day we are using for some patients. What is the overdose of the paracetamol? Overdose of the paracetamol in patients, you are getting acute liver failure or liver failure patients. What is overdose of the paracetamol, sir? How much paracetamol daily we have to give? Yes, sir.
Dr. Ravindra can answer this question better.
See,
Dr.
I think,
Ravindra.
I think Dr. Mahesh, this is a very pertinent question, sir. Basically, up to 3 grams, if you take, normally up to 3 grams, not a problem, but anything more than 8 to 10 grams, 12 grams, then it is a toxin, because most of the time we use 600 milligram, 650 milligram 3 times a day, that's okay. But sometimes we go beyond 8, 10 grams, then it is a problem. And for alcoholics, even 3 means somebody who is taking daily alcohol and they have alcoholic liver disease. For them, even smaller doses of more than 4 to 5 grams or 6 grams can also cause problem. And then especially people who have got diabetes, fatty liver disease, they have underlying chronic liver disease, because all diabetics, we all know, 1/3 of them, they have already cirrhosis by 15, 20 years. That's why they should not go beyond 3 to 4 grams.
3 to 4 grams, sir.
Yes. No, I think the safest limit, sir, Bidnal sir, the safest limit should be Dolo 650 or our Pyragetic 650, what we use 3 times a day. Beyond that, we should not go, sir.
Only 3 times a day.
Yeah, 3 to 4 times maximum. Don't go beyond that, sir.
In high fever patients, sometimes high fever, every 4 hourly, 6 hourly, they will get fever. In such patients, can we eat?
Sir, here we have to be, sir, we have to be careful whether they are diabetic for long years. Second thing is, if they are alcoholic for long years, that means we have to be careful, sir. That means we will have, already their liver will be compromised, then there is a problem. Young patient, of course, every 4 hours, 6 hours, if you give, also not a problem. But anybody who is diabetic for long duration, who is taking alcohol every day, I think these patients we have to be careful, sir.
Ravindra sir.
Yeah.
If we give more paracetamol, can we give Hepamers along with that paracetamol in such patient?
Sir, actually, Hepamers has got no role at all. Even in cirrhosis also, we should not be using. Hepatic encephalopathy also no use. Because Hepamers is only useful if they have got ammonia going up, hepatic encephalopathy is there. But it is not a protective drug when we use paracetamol or any other drug, sir. This is not a hepatoprotective. It only helps for hepatic encephalopathy in a very small set of patients, sir. Regularly, I think that is not going to be useful, sir.
Okay, thank you.
Dr. Ravindra?
Yes, sir.
What about this vitamin E?
Yes, sir. Sir, vitamin E, vitamin E, very good question, sir. Vitamin E is very useful for fatty liver disease. Vitamin E, we have to use, we do a ultrasound scan, and if ultrasound shows fatty liver disease, now most of us, we are also doing fibroscan. I think most of your centers are also doing fibroscan. If the fibroscan value, there is a value that is known as fibrosis value. If it is more than 8, we should use vitamin E. If fibrosis score is less than 8, then even vitamin E may not be useful. Only fatty liver disease with fibroscan more than 8, we should use vitamin E. Up to 1 year we can use, sir.
Hello.
Dr. Mahesh Gopshetty,
Yes, sir.
congratulations for your this one innovative project you have taken up. So anyhow, in the beginning it may be little bit this one, but in future definitely this may help for our liver failure patients. Wish you all the best in your new adventures.
Thank you, sir. I just want to add a few more things here. Our device will be tried in conjunction with the standard of care. So patients will not be robbed of any standard of care treatment. And we had this approval in place in PMSSY, that is Victoria Hospital, and some other private hospitals as well. So if you have any ALF patients, sir, my only request is send them early to me so that I can help them with my device. If they come very late, the device itself may not be helpful, and nobody will benefit at the end of the day.
Dr. Mahesh, Dr. Mahesh, Chandan here.
What will be the cost?
Zero cost.
Right now, as a part of clinical trial, the device itself is going to be free of cost. What the patient may have to bear is the standard of care.
Yeah, Dr. Mahesh and Dr. Ravindra, fantastic talk, Dr. Mahesh. Now Dr. Ravindra is there as well. We want to be part of to recruit patients for you. So I think I'll get in touch with you so that we can try and get our local ethical committee approval. Because recently we had an ACLF young guy. Probably your device might have helped. That's my personal view. Dr. Ravindra, we should try and get this on board.
Chandan, we have already approved, it has been approved at Fortis also.
Oh,
only it is already approved now because
ACLF,
ethics committee has almost approved. That's why most of the hospitals now we have started using. I think because this chronic liver failure, only thing is they have to get ethical approval.
No,
Otherwise, we
ACLF.
would have tried that in the patient we had recently.
Yeah, no, ACLF, we should try and
yes.
Local ethical committee, we should kind of amend it and get it approved so that next patient, early, we can use it early.
Yeah.
Yes, sir. For the ethics committee, we have already sent the letter. If you can help us expedite, sir, then we'll be able to get everything in place and start recruiting patients.
Excellent. Thank you.
Dr. Ravindra, sir.
Yes, sir.
Nowadays, we are getting a lot of non-alcoholic fatty liver disease.
Yes, sir.
What are the preventable measures for the non-alcoholic fatty liver disease?
Sir, it's Vidnant sir, it is a very good pertinent question. As I told in my introduction, the biggest liver disease presently in India is non-alcoholic fatty liver disease. We call it as now fatty liver disease. New term is metabolic dysfunction. MASLD is the new term. How to prevent this? One is all patients, we should tell them, especially patients who have got diabetes, overweight, obesity, we should tell them to do a diet control. Number one, diet control means they should have 2 meals. Morning 8 o'clock 1 meal, 2 o'clock 1 lunch. Dinner should be at 6 o'clock. They should have 1 jawar roti vegetable or 2 cups of ragi malt and vegetable. After that, nothing to eat after 7 o'clock. If they eat after 7, that will add calories and then more fat will accumulate in the liver. Majorly 2 meal. Third meal should be 1 roti and some vegetables. And then 2 cup ragi malt vegetable. Daily morning they should drink 1.25 liter warm water. That means almost 1/3 of the calories reduced. That is diet control. Second, they should do 30 minutes just walking is sufficient, brisk walking, and then 5 to 10 minutes muscle strengthening exercise. They can do squatting, means maybe some 30 squatting per day, or they have to climb 5 floors so that muscles they will get strength. This is diet. And third thing is we should do this is the preventive measures, and then good diabetes control, good blood pressure control, good cholesterol control. I think this is the primary treatment. Now the secondary treatment is we should do ultrasound. Ultrasound shows fatty liver. Then we should do 2 tests. One is liver function, second one is cholesterol, third one is hepatitis B and hepatitis C. And then this new test has come, that is known as FibroScan. FibroScan now almost every city they are getting. Very simple test. If you do FibroScan, if the fibrosis score is 8, then 2 medicines are approved. One is, as Dr. Chiniwala sir told, vitamin E, we give 400 units BD for 1 year. Second drug, there is a new drug which Indian company has brought. Just like our Mahesh is doing one Indian machine, Indian company now has got a medicine for fatty liver that is known as saroglitazar. 4 milligram we give for 1 year. This is the treatment. Diet, 2 meal, third meal before 7 o'clock, 30 minutes exercise. 10% weight loss they should do. Medicines approved for fatty liver are only 2 drugs. vitamin E and saroglitazar. This UDCA, Silymarin, Li52, SAMI, they have got no role, no use of these medicines for fatty liver disease.
If I can add a little more here, sir.
Yeah.
You know, common cause for fatty liver in our country is diabetes, overweight, and alcohol. So we have to address these 3 points if the patient has any of them. Diabetes should be well controlled. If they have body weight, they have to get it under control. And if they have alcohol, then they should stop alcohol.
Correct. This is 3 important things. Means basically what I tell my patients, take 2 meal, no third meal, 30 minutes walking compulsory, nothing to eat after 7 o'clock. This is very, very important. Daily drink 1 liter warm water. 50% there means 10% weight loss will happen in 6 months.
Yes, thank you.
Thank you. Thank you,
Sir.
Suresh.
Yes, sir. Very good, informative the subject, sir. And many of the hidden things are there, and many audience will be interested. And also, in after seeing this your video, also many questions will be there. One question is that, sir, especially this liver cirrhosis patient, whenever we refer, means they will usually already hepatorenal syndrome, as you told, creatinine should be more than less than 2. So what should be any criteria already you told? Just once again, just highlight, sir.
Sir, I just want, because the first phase of this study, it is basically to make sure that safety is of paramount importance, and we have to make sure that it is absolutely safe in humans. So, that is why these stringent criteria have been put in place. If we choose extremely sick patients, and if the patient dies, a lot of questions are going to be asked. Is the death because of the disease itself, or is it because of the device? If we are very adventurous in choosing these extremely sick patients, we may get our trial may not we may not be able to complete the whole clinical trial, and we need to understand our machine a little bit. Once we understand it a little bit, based on the sickness, if we need to use more number of cells, we have provision to do that. But I need to understand what is the cutoff level, above which we need more cells, below which we can use less cells. That is something that we have to understand. And once we understand it, even patients with creatinine more than 2, we should be able to use our device. But that question, I think, we'll be able to answer only at a later date. Did I answer your question, sir? I cannot hear, sir. Dr. Ravindra?
Yeah, I'm able to hear you. Can you hear me?
Yes, sir, I can hear you.
I think basically we should even in for liver transplant also, when we are taking these cases, when their creatinine is very high, we always give them a less success rate. That's why we should means to start with creatinine of 2 is a good idea, and then later on we can add on patients who are little more sicker also. I think that's a good idea to do that. And then even in, as you know, for liver failure who are on dialysis, we tell them the less prognosis only. That's why I think that's a good idea to keep creatinine which is below 2 mg%. I think that's the good idea.
If there are no questions, sir, so if you have any acute liver failure patients, please get in touch with me personally. And ACLF criteria, once we get approval in one of the hospitals, I will share the news with the entire IMA fraternity. And you can be in touch with me personally. depending on the financial capability of the patient, either I can accommodate them in Victoria or any of the private hospitals.
I think most important, Mahesh, we should give them all rat poisoning, because many of them are practicing in very agricultural belt. They have lot of rat poisoning, rat fever, rat killer poisoning. I think that is the biggest acute liver failure we can get. Day one, if you send, then if this machine is attached, because most of the time when they take rat killer, almost there is a chance that they will die. Out of 10 treat patients who take significant amount of rat killer, 8 or 9 will die. That's why all poor patients who have got this rat killer, farmers, I think they should be sent on day one itself, so that this machine is, before they develop hepatic encephalopathy, INR becomes 5 and 6. That's why these are the patients, if you send very early to Mahesh, I think that is a big, means we will have a good data. And then if these patients avoid liver transplant, and then they become better with this new EBRD device, I think that will be a game changer in Karnataka itself for all the agriculturists, especially when they have this rat killer, intentional or accidental or suicidal poisonings.
So these rat poison patients, on day one, if you see, they'll be sitting in the ward laughing and smiling. By the time they become very sick, once they become very sick, which typically happens on day 5, day 6, it is too late and they will not give you any time. And they go down the hill quite rapidly. So even though they may look very well on day one, we should still be very active and proactive in referring these patients. And maybe, using my device very early on, we will be able to help these patients.
I think rat poisoning day one, if we send, then most of the time I think this device will be beneficial for them. Rat killer poisoning, paracetamol poisoning, and then drug induced liver failure, especially AKT liver failure, and then paracetamol liver failure. These drugs, if we day one we send, before they develop unconsciousness or INR becomes more than 4 or 5, I think that is the one which will be beneficial for our all our patients, I feel.
Dr. Mahesh, will you share your number and address?
Definitely, sir. I will. Dr. Kagalkar has my number, sir.
Yes, sir. Yes, sir.
Take from your son, sir. I know him very well. I will take your number and I will send you my number.
Okay.
I'll share in the group, sir. I'll share his number in group.
Yeah, in the group you can share it.
Yes, sir. Yes, sir.
Thank you very much, Dr. Ravindra and Dr. Topsetti.
Thank you, sir. Thank you.
Very
For
good
excellent information.
Excellent informative information.
Sir, and one more last request is, in IMA, I think we should all make them all aware about this hepatitis B vaccination for doctors and nurses. All doctors hepatitis B vaccination, I think that drive we have to do, because wherever we have done the program,